All right, welcome to COVID-19 update for GPs. We're just going to commence now, 10th of June. So first of all, I wanted to acknowledge that we're meeting here at Adelaide PHN on the Kaurna land, and wherever you may be meeting tonight, we'd like to repay our respects to elders past and present and thank them for currently caring and previously caring for the land in which we're meeting here this evening. We've got a couple of things on tonight. We've got, first of all, an update from Dr. Louise Flood, the Director of the CDCB, around what's happening in the COVID space, which has been nice and quiet, which is wonderful. And then we have Dr. Tom Dodd here from SA Pathology, Clinical Services Director, who will give us an update about where things are up from SA Pathology perspective. We had that great talk a fortnight ago on the genome and where that was heading. So looking forward to hearing an update on where services are at with SA Pathology. We have Dr. Jenny Gould with us as well from the GP assessment team for COVID-19, and myself, Emily Kirkpatrick, RACGP Deputy Chair and SA Health GP Liaison. And then we're really excited as well to have a presentation this evening, which Adelaide PHN has very kindly organised for us around prescribing from the Digital Health Agency. And so we look forward to hearing from Laila a little bit later about that. So we'll start with Louise first of all, and so Louise is going to give us an overview of where things are at with COVID currently here in SA. Thanks, Louise.
Hi everyone, and thank you for joining us again. So I just give a bit of an update on the epidemiology. So this is from the 9th of June, over 7 million confirmed cases. I've got the list there of the countries, the most recorded cases, and that's the cases, confirmed cases does depend on the testing and how countries are counting their cases. So USA over, now close to 2 million cases, Brazil 673,000, Russia 476,000, UK 268,000. The deaths, over 400,000 deaths. The countries with the majority of deaths, USA, UK, Italy, Spain and France. And the case fatality rate is about 7%, so it's actually gone up a little compared with the last time we reported. But that really does depend on the testing and how you're picking up your cases. Here's the usual chart showing the numbers of cases on a log scale since the time that country first had 100 cases. So you can see that China, South Korea, Australia, New Zealand have had relatively flat curves for quite some time. But you can see particularly India's gone up quite quickly, Chile has gone up quite quickly, and USA right up the top there, quite a quick increase and is levelling off yet, at the moment, but not to the extent of the other countries I mentioned first. Looking at the epidemic curve globally, just by a World Health Organization region, the big players at the moment, the Americas, and there also has been, you can see that increase there in Southeast Asia that we've noticed over the past few weeks. Looking at the number of confirmed cases in Australia by jurisdiction, we've got over 7,000 cases across Australia. Those cases are predominantly overseas acquired and predominantly have recovered. And you can look, the larger states do have the larger number of cases, as you would expect. And there are relatively small numbers of cases under investigation. And here's Australia's epidemic curve. Still very small numbers compared with what we were having in March, which is encouraging, but we are still continuing to get cases, predominantly overseas acquired at the moment, but still some states do have some locally acquired cases occurring. So in South Australia, ours is been very encouraging the past little while with no recent cases. And so we do not have any contacts currently being monitored. They've all, because we haven't had any new cases for a little while. And so there's our epidemic curve in South Australia. Really not very many cases since the big peak that we had in March. And just our number of cases by age and sex, very small numbers in children. And just that reminder to continue your testing. Anyone who presents with an acute respiratory infection, an unexplained fever, or an acute loss of smell or altered sense of taste, and that it is notifiable, and we are going through the process of making it notifiable ongoing. And that's about it from me.
Thank you, Louise, for that update. So very reassuring that we're seeing low numbers. And then I guess the thing is now everyone's talking about restrictions. We've talked about the football coming back on this weekend, over 2,000 people being allowed in. And we're certainly getting a lot of pressure from the aged care sector as well about when we'll ease restrictions into aged care facilities as well. So very interesting times as we think about moving out of the acute pandemic. But will we see a second wave? Hard to know.
Well, I think it really just depends on what we do with our borders and what the appetite is nationally regarding keeping our international borders quite tight. I think that will make a big impact.
Yeah. It's all very, very interesting times ahead. So we're going to move now to Dr. Jenny Gould. We've sort of moved the order around a little bit just because Jenny's got some really exciting things to talk about. Not that you don't have exciting things to talk about, Tom, but we're just mixing it around a bit tonight.
Hello, everyone. So, yes, so I've just got a quick run through on a few things, which we've talked about these before, that life after COVID, that there are some people who have some residual physical symptoms, and there seems to be a large group that have some mental health issues ongoing. And so looking at the resources of how to support these. So you guys out there in general practice are best placed to manage these patients. You know them well, but we've added in some support in our template so that moving forward, any new cases that are identified will get a mental health phone call day 4 or 5 after diagnosis, and then again routinely 7 and 14 days after release from isolation. Obviously, if patients want to, or they've been identified as having issues, they can have continued support ongoing throughout that process, but those will be part of the regular follow-up. There are a number of resources available with regards to mental health, and this is from one of Emily's liaison updates with all the phone numbers. But we've worked out this new template working with Skylight, who provide the peer worker support, and they're available after hours, which is often useful for people, I guess those that are looking after COVID or have relatives who are COVID positive and are still working. And then there's the Uniting Community Support Service, which is also accessible, and that's generally 8 till 8 p.m. So these two groups will be providing that regular phone contact for patients, and they're also available for anybody who wishes to utilise their services, which is fabulous. I just thought I'd quickly go through the changes to the song, which has not changed a lot, but there's been a few changes recently. And we'll just do a summary through the criteria to release people from isolation. So those who are asymptomatic but positive, they can be released from isolation 10 days since their first positive specimen, unless they develop symptoms, and then obviously they'd they move out of the asymptomatic category. Those with confirmed or probable positive with mild illness, they then continue to meet the 7-day criteria from onset, as long as the resolution of all of their symptoms has been for the previous 72 hours. Those that have been hospitalised, these can be, if they're well enough to be released from hospital, but they're not over their illness, they can be discharged to isolate elsewhere, be that at home or in a hotel, and they would need to then meet the criteria of 10 days since release from hospital and a resolution of all of their symptoms for the previous 72 hours. If they stay in hospital, they again can be released from isolation following the 10-day rule and the 72 hours, but they must have 2 consecutive negative specimens at least 24 hours apart. So these are people that have got more severe illness, obviously. Just a few additional points to make, which are really explained in the changes in the new song, but pre-existing chronic respiratory illnesses, people who've got pre-existing symptoms like cough, well, then you need to make a clinical assessment about whether, when they meet the release from isolation criteria, that their symptoms of the acute illness have resolved, and what you're seeing is their pre-existing symptoms. There is a group of patients which will have a persistent post-viral cough. If they've got a negative test, they can certainly be released despite that cough. If they meet the criteria and they have a positive swab, for some reason they've been positive, they can still be released. And this is based on the evidence thus far, as these patients are very unlikely to be infectious. So despite the positive swab, they can still be released. If you can't get a negative swab in a case where you need a negative swab for release from isolation, then there is other ways to look at that data with the high cycle threshold values. So if these patients, this would obviously need to be managed in conjunction with the public health unit and infectious diseases and virology. So that would need to be referred on for some additional input. And people who've got a pre-existing productive cough, they would then need a respiratory tract specimen or the standard COVID swab to be negative before they could be released. So that's just a quick run through of the new changes. If patients redevelop clinical features, which we've seen in a couple of patients, we need to retest. If we identifying people retrospectively with serology, well, again, this requires public health input and clinical input, so you need to be flagging those patients. The big change, however, is really relating to returning to high-risk settings, that they no longer need to have a higher standard to meet release from isolation criteria, whereas previously we were saying those that are returning to a high-risk setting, like healthcare workers, aged care workers, were needing to do have the 2 negative swabs for clearance. But that is the biggest change. So that's really all I wanted to say, except thank you to everyone for continuing to be diligent and continuing testing, and hopefully we'll continue to see no new cases.
Thanks, Jenny, for that update. And I mean, it is quite difficult, isn't it, if you have had a patient who has previously been positive for COVID, then knowing what to do in terms of, do you retest? We do advise, and because the respiratory clinics are unable to see patients who have previously had been positive for COVID, we do advise that we can refer back quite easily through to the Metropolitan Referral Unit, the MRU, then back through the GP assessment team, and Jenny's been doing a great job reviewing those patients again, and that may be, you know, that they do need another clinical assessment, another swab, those sort of things, but always keep in mind that you can refer back through that system, and you can just send me an email and I can put the referral through, if that's easier for you as well.
I think that's a good point, Emily, because if they present or try to book online to those respiratory clinics, it will say, have you had a COVID positive test in the past, and then you cannot progress through the booking system, so they need to come back through MRU. And
Yes.
yeah,
Yes.
And you can be the point of contact because you've got nothing else to do.
No,
with your
I'm very
test.
happy because often it can be quite stressful for both the patient and for the GP. And now I just thought I'd put this up. We've had a few questions come through the chat box around, should my child get tested for coronavirus? Now this resource has come out in response to all of your feedback about parents coming in saying that they are not going to have their child tested for COVID because they don't want their child having something stuck up their nose. So it's really important at this stage. We are still strongly encouraging that you test everyone with acute respiratory symptoms. And you'd agree with that, Louise? That's the message, CDCB Health Alert current message.
That's correct. Because we really try, we don't think that there's community spread, but the only way that we can be sure about that is by continuing to test. And we could get an introduction that we're not expecting. We could have someone come from interstate. There could be someone come from overseas that's come from another state or something. So we always need to be vigilant, and we need to keep on testing so we can detect if there are any cases and we can respond to them promptly. And that's the way we'll keep on top of this. Well, one of the key ways.
So yeah, Louise, on that one, I've had patients contact me where the family have got like a respiratory illness and mum or dad or both get tested and they're both negative, and then they say, well, you know, clearly we've all got the same thing. Do we need to test the kids? And really the answer is everyone should be tested.
Yeah, that's the message. Everyone should be tested. It is sometimes people can have different illnesses even though they all get sick at the same time. I mean, different causes. So we still would encourage everyone to get tested. If they have an acute respiratory illness, that unexplained fever or the loss of sense of, or change in the sense of taste or smell.
So very important that you can put this up on your clinic Facebook sites or however you can get this information out to your patients. It is really difficult because, as has come through the chat box, you know, it's hard to often see young children in your practice if you don't have PPE or you don't have the space to safely examine. So it is really important to either think about other testing options, so either respiratory clinic, a drive-through test, attending a COVID clinic. The COVID clinics have been very busy this week. It's so important to think about how you can have your patients seen. And we are very happy at SA Health. The PHN has been supplying so much PPE out. SA Health is happy to supply out additional PPE if you can't get it through other means. So please send an email. Let's try and get everyone getting PPE now while we've got lots of stock available so that you can see your patients. Because it is very difficult if you've got a little baby with a otitis media, which has just come through the chat box. How do you then deal with that? It's really important that they are still seen and they're not just sent off for a test that may take a couple of days. You know, by the time they get the appointment and get the swab result comes back, to be getting onto that ear infection, and reassuring the parents that they need their Nurofen or their paracetamol, no antibiotics, those sort of things. So yes, please take note of the poster. It's available on the SA Health website, and I'll put the link out in today's GP update as well. Now, I'll tack this onto your slides, Tom, so I'll go back to your slides at the beginning there, and I'll bring the speaker closer to you as well. So thanks, Tom. And you've been very busy testing as well at SA Pathology.
So
this is your very busy time.
Good evening, everyone. So I think 2 weeks ago, the message was about test, and everyone took it very seriously. We had a record week last week in terms of testing for any period. So right at the height of when the exponential growth was happening with the virus around sort of early to mid-March, we had a record day of 2,361. But as you can see, in the last week or so, we have had multiple days over 2,000. So that's pleasing in the sense that obviously you folks are referring patients for swabs. The private pathology providers now have options as well. They've got drive-through services. So I encourage you to use all pathology laboratories that are available, I guess, based on geography where you've got your patients, where they live, and take advantage of the expanded testing capability here in South Australia. It's, I guess the other thing is it probably means, as you know, there are some viruses being transmitted out in the community, and so, which means that that there is some breakdown in all those things that are preventing the transmission of virus. So should we get a case of COVID lob up in South Australia, it has the potential to be transmitted. So really important that we continue to contest at this very high rate. Next slide. So the other thing we're doing is looking at different demographics for some surveillance testing, and I think we've mentioned this previously. So we've got to focus on a number of groups of people who are either at slightly higher risk or somewhat marginalised from the sort of normal healthcare systems out there. So in the Adelaide, we've now swabbed over 200 people who are homeless. We've got a very good program happening up in the Riverland now to swab seasonal workers, backpackers who are living up there in sort of hostel accommodation, or I guess slightly higher risk because of their living arrangements and so forth, some of which of course travel in from interstate. Starting this week, prisoners, people entering the prison system will be swabbed on a regular basis. Pretty much everyone going into prison will have a swab done. We've moved our truck stop to Tailem Bend, and I think we're seeing a bit of a pick-up in the truckies taking advantage of that. And there's also going to be, I think, some further work around swabbing healthcare workers as well, including GPs. So I think there's a bit more to be rolled out around that. So at the moment, we've been looking at different groups, but healthcare workers obviously are sensible and aware of their options for getting the swabs if they're symptomatic, but we're going to look at the way in which that might work for asymptomatic health care providers as well. So that's really where we're up to. Very busy, and we're pleased that that's the case.
So Tom, a few questions we had through around serology. Is there any progress at all in the serology space at all?
So with regard to serology, I've said this several times before, it will be important. I guess because of the fortunate position we're in South Australia at the moment, it's probably not as critical as it might be. Having held off, there are two good things about that. The first one is we will ensure that we get the best available test in terms of sensitivity and specificity. There have been some serological tests available already, which probably are not as ideal as we'd like. So having waited for the very, very best technology. The other thing is will also be the most cost effective, because the major companies will be sort of matching their prices for tests. So we anticipate having serology available, I keep saying 4 to 6 weeks, something in that time order, but it is close to time to have that available.
Yeah, and I think that is really important to keep in mind, that it's just not there, is it, Tom, in terms of the sensitivity, specificity. When we talked about this a couple of months ago, we thought, maybe a few weeks here and there, but we've got great testing with our PCR currently. So
I think the important thing to remember, given the relatively low prevalence of COVID in South Australia, if you do a serological test today, randomly on a patient coming into your rooms, the positive result is far more likely to be a false positive and cause you far more grief. Obviously, if it's someone who's returned from the UK or the USA, who had symptoms or something, a few months ago, you improve your probability that the test will be true positive. But randomly going out doing serological tests on people at the moment in Adelaide, I think would cause us a lot of grief.
And is there any plans at all? But Jackie's just posted a question around what will serology be used for in the future. Is there any thought in that, Tom, at all? Once we do have that capacity, what we could use it for?
Look, I suppose it'll be useful for people who have potentially been infected and have recovered from their illness going back retrospectively. I guess there'll be some other options, but Louise might have a better idea than me how that'll be used in South Australia.
I just wanted to say we have already used serology in South Australia, just because we can get the tests done interstate when we really need it. So really, it's been used in close contacts of known cases, particularly when they've had an illness, they've had a PCR that's negative, and then they've had an illness that you know, it's consistent with a COVID-like illness and getting serology done in that circumstance. And also, if there's a known case and we're trying to link testing some close contacts. So really, as Tom was talking about increasing that probability of it actually being a true result when we get it, so that they are those in really higher risk groups because we know they're a close contact. So we have already used it. That you just really do have to be careful with it when you're doing the wider population, because we don't think we've got much COVID around, and so any test is much more likely to be a false positive at this point, unless you've already narrowed it to a higher risk group.
Yeah, that's a very good point, isn't it? And it's good to hear that there is that ability if you do need it in those really specialised particular cases as well. In terms of SA Pathology, you're doing lots of tests at the moment, Tom. What's sort of the time frame of getting an appointment at a drive-through testing clinic at the moment? What's your wait time approximately, do you think?
I still think we're getting, well, there are record numbers of patients coming through, but we're still getting people through within the next sort of 24 or so hours, I believe.
Right, that's very reassuring. Thank you.
And just to reinforce, there are multiple options, multiple drive-throughs now in lots of locations, north, south and central. So encourage people to make use of all the services.
Yes, and certainly children are being swabbed as well at those drive-through clinics, aren't they?
Yeah, that's right.
So we often get that as a question through from GPs saying, you know, can my 6-year-old be swabbed at this clinic, or can I refer this patient through the drive-through? And you certainly can refer, which is fantastic. And as Tom just said, there are other providers out there, so ACL, ClinPath, SA Pathology, all offering drive-through testing options. So please look up online, refer your patient to who you prefer to refer to. It's really important to get people tested, is the key message, even with mild symptoms. So thank you, Tom, for the update on SA Pathology. Anything else exciting happening at SA Pathology in other areas as well, Tom?
I suppose the only other thing to note is we've opened a new clinic for vulnerable patients, immunologically suppressed patients at Mile End yesterday, I think. So now we have one at Unley, one up north at Elizabeth, and now a slightly more central one at Mile End. So if you've got patients who are immunosuppressed or other sorts of illnesses that need to come in and have routine bloods done, they're good options for you.
Yeah, and also the domiciliary visits as well, they can have as well for blood tests, and also for swabs, is that right as well?
Yeah, that's right.
Now there was a question that just came up, do we know what the testing is happening in the private space? So I sent out last week in one of the GP updates that there was a new direction around just so we can get some data and reporting at SA Health what's happening in the private space as well as the public space, so that all providers are required to submit their data and how many tests that they're undertaking. And I understand that data will come through at the end of the week. So once that's available, we have an idea that I'm very happy to share that out. So we have a better picture of how much testing is happening. And I do understand that both ClinPath and ACL are doing quite a bit of testing, and ClinPath also is doing testing in the aged care space and domiciliary visits, just like SA Pathology. So keep in mind that you can call up either company to book a test for your patient if they're in a residential care facility.
So we are receiving that data for one of the private labs already. But that direction is now enforced, so we should start to receive it for the others as well.
Yes, and then that'll help us have an even better picture and see how much testing we're doing, and we might catch up to Victoria again, where we were a month ago when we were out doing everyone. Wonderful, thanks Tom for that update. So now we're going to hand over to our guest speaker from the Digital Health Agency. I'm just going to stop sharing my screen here, and we'll just open up to Laila. So Laila Tabassum is from the Australian Digital Health Agency. Wonderful, perfect. Thank you, Laila.
Good evening, everybody. Thank you for inviting me to come and do a little bit of an introduction to electronic prescriptions to the audience. So what we want to, let me see. Okay. All right. Next. Fantastic. All right. Excellent. All right, so before I start, obviously, I would like to acknowledge the traditional owners of the land in which we are meeting today and pay my respect to elders past, present, and emerging. And if there is anybody in the audience today, I would like to extend my respect to them as well. So what what we're going to, I mean, it's a very, very short presentation that I've got today. And what we'll do is we'll just try and identify the core features of electronic prescriptions. What are the benefits we are expecting from it? And, you know, how a prescriber might use it in their, you know, practice and things like that. And also if the certain requirements that's there for our organization to start using electronic prescriptions, and what are they? So we'll just focus on that. So as, I mean, you know, most of you would know, so in October last year, the federal legislation was changed, and electronic prescriptions were, you know, is a legal form of prescription at the moment. So previously, paper prescription with the signature from a clinician was the only accepted form of prescription. Now, if that prescription is in electronic format, and obviously following the conformance requirements and things like that, in that instance, it is obviously a legal prescription. So, I mean, you know, there is no compulsion on anybody to take it up. It is just another option that is available. And it is essentially to give patients a lot more, I guess, flexibility and choice. And when we, you know, think about, I mean, as we are talking about COVID, we're still talking about COVID where, you know, there is, I mean, in SA, obviously, there hasn't been a lot of cases detected recently, but, you know, it's still the possibility and all the things that we have to be on guard. So obviously, in these kind of instances, this kind of electronic methods are, I guess, a lot more useful to consider. So there are two kinds of, so I mean, obviously when we're talking about the prescriptions will be in two kind of formats. One will be in a token. So it's essentially looks exactly like when we have our boarding passes on our cell phone. It's a QR code, and the QR code is not the prescription. What it has is that it is obviously the encrypted form of that. That is not the legal form. When that sort of is, you know, at the pharmacy end, when they scan it, that's when the prescription will come down. This is a will be obviously progressively available from the, you know, has been available the 30th of May. And, you know, it will be, I mean, obviously we'll be seeing a lot more of it. The other form is called active script list. So when we think about probably the main difference in the two is that when we think about somebody who's not on regular medications and just needs a one-off script for something, in that instance, that person could probably have a you know, prescription made out into a token model. The active script list would be, you know, a person may have, you know, 2-3 different medicine that they're on a regular basis. In that instance, you know, which token is this medicine for, which token is that medicine for, sort of, you know, not trying to sort of play that guess game. A script list would be available at the pharmacy end, and they would be able to, patient would be able to say, patient will have obviously have access to it and would be able to say, well, you know, this is the medicine that I need at the moment. So yeah, so those are the two different ways that's going to work. So the first cab of the rank is obviously the token model. That is what we are working, and so the active list would be starting that work towards late 2020. So obviously, who can participate? As I've said previously, this is not mandatory. Not everybody has to participate, but if anybody wishes to participate, they can. So prescribers, as prescribers, you know, doctors, you know, specialists, GPs, even, you know, nurse practitioner who has the authority to prescribe, a veterinarian, optometrist. Those that usually prescribe can participate in the electronic prescriptions program, you know, to make out an electronic prescription, I guess. But then again, obviously, we have to, I mean, specifically mention that the federal legislation has changed, but the state and territory legislations are getting updated to accept electronic prescriptions as a legal form of prescription in the state and territory. So that's that work that's happening at the moment. The dispensers, obviously, a pharmacy, they can choose to participate in it. Software providers, I'll show you a list of the software providers that are currently conformant. So obviously dispensing, prescribing software and things like that. But one of the most important softwares that is integral to electronic prescriptions is prescription delivery services software. So there are two softwares in Australia, ERX and Medisecure. So most general practices would have that incorporated in their software system. So that would be there. And obviously consumers, as we've said, that it is essentially to give consumers a lot more choices. But consumers, a consumer that has got a IHI, so obviously a consumer who has got a Medicare card or a DVA card, and they've got an individual health identifier, in that instance, obviously, electronic prescriptions can be made for them. Specific thing to note here is that existing prescription, paper prescription, cannot be transferred into electronic prescription. So the electronic prescription obviously has to be, it has to start as an electronic prescription. So this is the conformance register that we've got on our website, and it is obviously regularly updated. You would see that this is from the 2nd of June. As more and more softwares are working on the conformance profile, and that gets sort of updated. So you might not see the software that you use, but that doesn't necessarily mean that that work is not happening in the background. So that is something, it would be good to sort of keep an eye out for that. So let's look at a case. I mean, given that we are still in COVID situation, how would electronic prescription work? So if we think of a patient, typical patient who is an elderly patient, James, who's 72 years old, he's got hypertension, he's got diabetes, he has had a knee surgery and hasn't been very active, lives on his own, and doesn't own a car. So he needs his regular meds. But obviously, given when you think about it, he's got hypertension, he's got diabetes, so he's one of those more high-risk patients. So obviously, with the GPs doing telehealth consults, for James, the GP would definitely do a telehealth consult. But in that instance, to give that prescription, the GP could actually make that prescription out as an electronic prescription via the token model. Now, if James is not confident to receive that token in his maybe because he doesn't own a smartphone, maybe he doesn't feel that confident using digital services, he can always ask for someone to one of his carers, family member or somebody to sort of the token can be sent to that person. And obviously then the pharmacist can, James can, once the James receives that token, he can obviously send it off to his pharmacist, who can dispense the medicine and send it over, delivery services and things like that. That's happening. So it's pretty simple. So it's at the time of prescription, the GP obviously needs to ask James, I'm doing a prescription for you, would you like electronic prescription? And if James says yes, I would like electronic prescription, the prescription making our process of prescription is exactly the same, and obviously just choose the electronic format. And then obviously the system will ask how does the patient want to receive it. So the patient can receive it as SMS or obviously as an email. So I'm showing it's obviously this is just for demonstration purposes, and it's from one general practice software. So it actually comes up with where to send the SMS, which number to SMS the patient, the information to. So obviously, the GP can actually override. Let's say there is a number on the patient's profile, and because the patient doesn't have a smartphone, patient can't actually receive the SMS. So in that instance, the patient can give the number for their carer, and the GP would be able to put that number in. That number would not stay in the software, but obviously they would be able to, send that in that instance, that prescription can be sent to that carer. So how would it look when it will say that your prescription is ready, and when clicked on it, it will come up as that QR code, what medicine it is for, and obviously you can see on the top here it just gives the patient's initials. It doesn't give a lot of the detail about the patient in there. And if the prescription was sent as email, it would come up in the email looking like this, and when you can click on it, it will come up with that QR code, obviously, in the middle of that prescription. And obviously, when the patient takes that code to the pharmacy, all they will have to do is scan it, and it will bring down the prescription onto the dispensing software. Now, if you just see that in these three screenshots, there is no QR code that's coming up. So if a prescription has expired, there will be no QR code coming up on the patient's phone. So if they have a token, but obviously it has expired, they haven't gone and got the supply, it will not come up with the token. Same will be if the prescription has already been dispensed. So if a patient has a prescription and they have forwarded it on to somebody else to pick it up, but then they sort of thought, oh, you know what, I'm just going past the pharmacy, I'll pick it up. And as soon as the pharmacist scans the token for that prescription and dispenses that medicine, the other token, even if there is another copy somewhere else, would be locked, and they will not be able to dispense that medicine. And obviously, if for any reason there has been a change, there has been some sort of an issue, and the prescriber can also cancel the prescription. And in that instance, no QR code will be coming up. So we get this question quite often: who will be, bearing the cost for this SMS that's going out to the patient? So at the moment, obviously, because of the COVID situation, the department, Department of Health is funding that for the timing up to September, because that's part of the National Health Plan. But obviously, after that, it will be important to sort of check with your software vendors. So what we are doing is, at the moment, the department is working very closely with the software vendors, and the software vendors are quite cognizant of the fact that they didn't want to sort of add any additional cost. But I mean, obviously, we don't have details of how it will work for each software vendor. So please do check with your software vendor how they want to go forward with that. So there are obviously, we have created a lot of communication resources. So if in the instance your practice wants to participate in electronic prescription, to make sure that your patients are aware that you are electronic prescription enabled, you can have obviously posters, flyers and things like that available for them. Obviously, we've got web banners and emails and things like that. If any of these things you want to use, it can be. So these are something that's being gradually rolled out. So it can be ordered from our website and things like that. And the PHN will be able to share that information with you once all the collateral is ready to be shared. So let's just talk about a little bit about how, as a general practice, you would be able to sort of participate in, if you wanted to give that, have that option to provide your patients with electronic prescriptions. So one of the important things for electronic prescriptions is to sort of to identify which organization is, from which organization this prescription is coming and who is the author of that prescription. So as you may be aware, the national sort of identification is the healthcare identifier that we have. So for the organization, it's called a HPIO, a healthcare provider individual organization, identifier organization, and then healthcare provider individual identifier. So obviously, as GPs, you would have a HPII, which is linked to your APRA registration, and your organization will have to have a HPIO. So a lot of the organizations may already have a HPIO because it's the similar sort of infrastructure that's used for My Health Record as well. So obviously, that having that HPIO, and also NASH certificate is required by some software to authenticate the process of the transfer of the electronic prescription. The other important thing that obviously we need to be aware of, obviously the conformance software. So if the software that you're using in your practice, if it is on that conformance register at the moment, so if you upgrade to the latest version, you'll probably be able to use the system. But along with it, we've got another thing that we need the practices to be connected to, which is called a prescription delivery service, as I've said before, ERX or MediSecure. So the way it works, if we sort of look at it, the workflow, the way it works as a GP, when you're writing that prescription goes to the prescription delivery service and it gets encrypted. And that QR code comes down and that gets transmitted to, whichever way you want to send it, whether it is as a SMS or as an email, it goes to the patient. But the prescription gets stored into that prescription delivery service. So when the pharmacy scans that QR code, that essentially pulls down that prescription from the prescription delivery service to the dispensing software. So obviously, there is, the need for transcribing and all those things are not there, but obviously, that connection is really, really crucial. So with your software, you need to have connection to that. So, both the software are free for healthcare providers. So you can obviously, if you don't have one in your practice, it would be important to sort of get that. One of the ways to see is that currently when you are writing a paper prescription, when you print it, if there is a barcode or a QR code that comes up on that prescription, you probably have you definitely have one of those, either ERX or MediSecure. The other thing obviously is to make sure that once you've got your HPIO and your HPI and all those things are obviously in your software integrated properly, and the patient's IHIs are getting validated. So for a lot of general practices, this is business as usual, but for some reason, if your practice hasn't been doing it, there is obviously the information available on our website, and the PHN can also support you with that. But obviously, as we're saying, that this is a prescription that is going to go to a patient's mobile phone or their email, it is important to make sure that we have some workflow happening in the practice at the moment to update the patient's contact details, whether it's their mobile number, or their carer's mobile number, or the email address. That needs to be, I guess, in a way, updated. But also the other thing, as I said before, that it is important to sort of make sure that you are aware of what your state and territory legislations require. So as there are definitely different nuances for different states and territories, and how they want certain things to be done. So obviously it's important to be abreast of the information that's coming from the state health. So SA Health, you'll be able to sort of get that information. Obviously, if you are using that, and if your if your practice wants to utilize that, making sure that the admin team members are also aware of it, and we can they can sort of answer patients' questions and things like that if the patients are asking questions. So we've got a suite of resources on our website. I mean, obviously, we will share the slides with you, and you can obviously go through the link and see that information. But some of the other things that we've heard in when we've done these kind of presentations in other places, what a lot of the general practitioners have said, well, how do I know which pharmacy is using, will be able to dispense electronic prescription when I am, making that out, a prescription out like that to my patient. So what we have heard is that having that conversation with any local pharmacies or things like that that you may have, that, I guess in a way, healthcare provider to healthcare provider, having conversations that, if this is something that you're doing, we have adopted electronic prescriptions. Are you guys dispensing electronic prescriptions? Same thing the pharmacies are doing. They're actually sending out emails to the local general practices and saying, now we can actually dispense electronic prescription. So if your patients, if you are utilizing it, you can always ask your patient to drop in, to our pharmacy or something like that. But I mean, obviously, this is something, it would be good to sort of have that knowledge, what's happening in your local area. So obviously these are the resources. One thing I forgot to mention previously is when the prescription has been made out, when you've given that prescription, it's really important to confirm with the patient that the patient has actually received it, if they've received it as an SMS or as an email before the end of the consult, because we don't want the information to say obviously going somewhere else. And this is something we get asked quite a lot, that, what if it has gone to somebody else's mobile or something like that. I mean, it's possible, if there might be, if it's being sent to a different number and it's not the patient's regular number, then, instead of 6, if, the doctor writes 9, then obviously it might go. But if the prescription hasn't been received, it can obviously be cancelled from the GP's end and can be sent to the number that is the correct number. So and that's all I had to say. I went very, very quickly. So yeah, happy to take any questions. And if anything needs more elaboration, I can do that as well.
Wonderful. Thank you so much, Laila, for that very informative presentation. We've had a few questions come through for you. The first one's been around security. So with SA scripts, will e-prescribing have mechanisms in place to flag these scripts to patients IHI as a person with a script obtained via fraudulent means? That's come up through the Q&A box. I don't know if you're able to comment at all on that.
So obviously, I mean, when you I mean, with the electronic prescription, so you've I mean, whether it was somebody sort of misrepresented themselves and got the healthcare provider to sort of give them a prescription, I mean, that's possible. I mean, that's possible at any time. And a lot of people do that because that's quite they're quite smart when they do that. But I mean, obviously, the healthcare provider will have to do that. They have to give out that prescription. As I've said, if it was sent to a wrong number, and the patient says that, no, I haven't received that, in that instance, obviously, it can be deleted. But obviously, with S8s, I mean, even though the legislation permits that, if there are specific requirements for the state legislations, I mean, you'll probably have to sort of clarify that at that level, if that makes sense. Because, I mean, what we know that, I mean, when I was talking to a group of GPs in Victoria, they were saying that they have to retain the paper copy, and there was a lot of issues like that for S8s. So, I mean, obviously, I'm not sure, I'm not totally across the SA legislation, but obviously, if there are certain things like that, that would be, something to look out for. But I mean, I know that the real-time prescription monitoring, it has started in the SA, hasn't it? real-time prescription monitoring?
Oh, not yet.
Not yet. Okay, yeah.
It's underway. Hopefully September, I think.
Yeah. So that would be helpful, you know, to sort of look at if somebody is obtaining something fraudulently and things like that. But yeah, I guess that I really can't comment any more on that.
But certainly the code can be cancelled as well.
Yes, exactly. So if the patient hasn't received it, so essentially if somebody misrepresents themselves and the doctor has actually given them the script, there is really nothing, you know, anybody can do unless, you know, the patient prescription at the pharmacy end, the pharmacist, it raises a flag with the pharmacist. In that instance, they might be sort of able to not dispense that, cancel that, or talk to the doctor. That would be your usual mechanism anyway. But you know, but if it has gone to a different place, as I've said, that let's say if it is a SA prescription and I have received it and I've also forwarded it on to one of my friends to get it dispensed, without understanding that I will not be able to get to prescriptions, you know, to a lot of medicine. So if I have gone to the pharmacy and the pharmacy has actually scanned the barcode and they are the QR code and they have started the dispensing process, that has been locked. So even if my friend goes in the next second to the pharmacy next door with the same script, they will not be able to get that dispensed because that code will be blocked in the prescription delivery service. Does this sort of make sense?
Yes, that's really helpful. Thank you so much for that. The other question we had as well was around carers. So sending a code to a carer, are there any privacy concerns at all around that? Or how can you get around privacy in terms of documenting in the notes? If you have any suggestions at all, Laila, for how we could deal with that in general practice?
So obviously, I mean, you know, when we are talking about carers, I mean, usually if it is your regular patient, you know, as a GP, you would probably know who the carer is, usually. So in that instance, I mean, you know, I guess, I mean, how do you deal with it at the moment? So let's say patient's daughter, who's the usual carer, comes in to sort of pick up a script. You know, what's the process that you follow? It really wouldn't be different to that. It is essentially, it's just the electronic format of it. But I can definitely take that on notice if there is anything specific that the GPs need to do, and I can definitely send that communication to the PHN, and that can be shared with the GPs.
Wonderful, thank you. Yes, it's all very uncertain times, isn't it? But wonderful to see that e-prescribing is really taking off. And I just put in the chat box as well that we're hoping to get the legislation passed in the next day or so. So once that's out,
That's exciting.
Yes, it is very exciting. So we've had lots of exciting things happening here with prescribing in terms of so using an image base for prescriptions, e-fax legislation as well was uncovered, and now e-prescribing. So very exciting for GPs to be able to offer this option for their patients as well. So thank you so much, Laila. Was there anything else or any take-home messages you had for GPs at all?
So I guess in a way, you know, it's probably important to sort of, you know, be prepared for it. I mean, there is a lot of discussion happening. People will start sort of maybe coming in and asking for it. If there is any specific information you guys need, let us know, and you know, we'll be able to sort of provide that. And the more we hear from the provider community, the more we know, you know, what sort of resources the provider community requires, and similarly, you know, the kind of questions that they are getting from their patients, that helps us sort of address the consumer needs as well. A lot of the things that we are doing, we are discussing with the consumer community and the provider community, but the more feedback we receive, the better it is for us. So please, you know, keep it pouring. Yeah.
Wonderful, thank you so much. So we might leave it there now. So thank you so much for joining us for this evening's webinar update for COVID-19 for GPs. We've decided that we're going to move these to a monthly based webinar just because we feel that SA is doing such a good job. Thank you so much, Louise and Tom, for doing such a good job here in SA, keeping our numbers really low, which is so wonderful. So I wanted to thank Adelaide PHN, who's been hosting the webinars for us, and to the AMA for being involved, the RACGP, SA Pathology, SA Health, the GP assessment team. It's been a wonderful collaboration. So it's so wonderful to be able to discuss what's happening with COVID. And I hope that you've been able to take some key messages from this here, because it's been really important, I think, for us on the front line in general practice to be able to really care for our patients who have been both positive with COVID, but those who are requiring testing, who are anxious, who are isolated, who are really feeling the effects of the pandemic. So thank you so much for joining us this evening for tonight's webinar. And as usual, please send through any questions. Keep the complicated questions coming through, and I'll redirect them through both Louise and Tom as required, which I'm sure you'll be thrilled about. And thank you so much for all your active participation as well with these webinars. And we look forward to holding our next webinar soon, so perhaps in a month or so, but we'll keep you posted through Adelaide PHN as well, and through the SA Health GP Liaison emails. Thank you and good evening.
Thank you. Bye-bye.
Thanks, Laila.
Bye.